3, 2, 1. And the red light's flashing. That means we're live again for the latest in our community spotlight series. I'm so pleased today to say that we are with Jeffrey Skubic, who is the Trauma Medical Director at DHR Health, and he's also the Assistant Professor of Surgery at UTRGV School of Medicine. Jeffrey, great to see you.
Thanks for having me.
As probably everyone in the Valley knows, DHR Health is a level 1 trauma centre, and it's Trauma Awareness Month, and we got about 5 or 6 questions for you. Can I ask, first of all, what is your primary role and responsibility with DHR Health's level 1 trauma centre?
Sure, great question, Steve. Clinically, I'm a trauma surgeon here, which means I take care of patients that need emergency general surgery, trauma surgeries, or intensive care in our surgical ICU, our intensive care unit. So those are the clinical roles that I play, in addition to doing some elective general surgery. In regards to the trauma center, I'm the trauma medical director for it, which means I am the lead physician for the trauma centers for the physicians, as well as organizing schedules, keeping us on track to meeting our requirements to maintain our certification as a trauma center, as well as keeping all our protocols up to date and helping to run the whole trauma department, as well as all the interactions with all the other departments here in the hospital.
Thank you so much. Next question. Tell me about the different levels of trauma care and where DHR Health ranks.
Sure. So in this country, there's 4 levels of trauma care, level 1 through 4, and they, with decreasing numbers, goes down in the availability of care they have. So level 1 trauma center is the highest level of care. That's what you would expect to get at a high academic tertiary care facility like UT San Antonio or UT in Austin or Dallas Southwest or Stanford or big name places like that. Those are all level 1 trauma centers. It means they can provide the absolute highest level of care. It means there's nowhere else for the patient to go. The buck stops there, and that's where they take care of the worst of the worst. And all the smaller, lower level trauma centers will transfer patients to them as needed when they're above what they can take care of. Level 2 trauma centers are just below that. They can take care of a wide range of patients as well, sometimes very ill patients, but they may not have as high as a requirement for coverages and so forth as a level 1. Plus, they don't have as big of an effect on the community in regards to research and education. Meaning, when you're at a level 1 trauma center, you're at the forefront of trauma care. You're the ones doing the research, setting the guidelines of how communities should be taking care of patients. And then level 3 trauma centers would be they can take care of a good deal of sick patients, but maybe not at all times, and they may not have all specialties all the times. And then level 4 are in more remote or rural areas, and they kind of stabilize the patient and then get ready to ship out to a higher level.
And as we know, I think it was last year that you gained that level 1 trauma center status, that certification. We had Governor Abbott come down with a lot of fanfare. How important was that for the Rio Grande Valley to have a trauma level 1 center?
I think it's an important step forward. There's a lot of hospitals here that take care of trauma patients. Obviously, one hospital here can't take care of everything. Goodness, we wouldn't want to, right? It's too much. But before you have a level 1 center, you can't really say you're a complete trauma system in and of yourself. And the Valley traditionally has been reliant almost as an outpost of San Antonio. And going back for decades, any sick patients, they would just ship them out of here. And that's typically still what goes on in other smaller urban parts of the state, even in South Texas. And they would rely heavily on those bigger cities like Houston and San Antonio. When we finally got a level 1 trauma center here, it says, okay, of all of the hospitals we have here in the system, the Valley can now stand on its own 2 feet, because no one should have to be sent outside of the area. We're no longer reliant and crutched on another neighboring community, which is 250 miles away, quite far to send the sickest of the sick patients who might not even survive the journey there so far. that doesn't have to happen anymore. Now we can say we're a complete system. No one should have to leave the region, and we can work with all the other hospitals in our region to appropriately care for patients, help them, keep them there if they can, send them here if they need to, and kind of become the big brother for everybody.
And so how much effort was it for DHR to reach that level 1? How much work did you have to put
A
in?
huge amount of work. Ask our families. No, really, again, it truly is a joint effort. The only way this is able to happen at any institution is if you have true institutional level support from the bottom all the way to the top. All hands have to be on deck and all supportive. All departments, emergency department, radiology, OR, trauma departments, administration. If you don't have backing of all those people, you can't do it. You're talking, it's estimated, I don't know the exact figures here in this particular case, but it's estimated it costs about $10 million a year just to maintain a level 1 trauma center, from all the specialists and all the extra care you have to have. It truly was a tremendous amount of work. Everybody on the back end, even outside what people see, we're working nights and weekends. The last year working up to it like crazy, just trying to get everything in order. There's so many protocols you have to have in place, and every single thing has to be in alignment. If you don't have enough papers published, you don't get it. So and those things take time. So it was a tremendous undertaking, huge amount of support from all the different specialties and everybody. And
You must have all been so proud when it happened.
oh yeah, when we had the American College of Surgeons survey, it was a virtual visit, and I should go back and check the numbers, but we probably had 50 to 75 people connected to the meeting. I think we almost shocked them when they did the review of us. There was like 75 people plugged in watching. They're like, who's all these people? But it was such a big deal because they never had a level 1 down here before. It was such a big step up to finally say, hey, we can provide the same level of care that other big cities can in Texas, and that the population down here isn't second class, and they can stand on their own 2 feet, and it's justice for the people, so to speak.
We here in the Rio Grande Valley, we don't think of ourselves as just the valley. We've got family and friends the other side of the river. How do their hospitals compare to that? They probably have different protocols, but do they have a level 1 trauma center, if such a thing exists there? And if not, do you find residents from say Reynosa coming over to utilize your skills?
Also, good questions in regards to the other side of the border. They do have some big hospitals there. We know some of the surgeons there, as well as in Nuevo León and Monterrey. Now in Monterrey, they have very big hospitals, very well staffed. Probably that city is more well off than our region, quite frankly. And so if you can get there, the level of care is very good. The level of care in Tamaulipas is a little bit more scattered. The difference between, there's good surgeons over there, there's good nurses, just like there are on this side of the border. But the difference in the level of care that you find is as soon as you cross the river, they don't have an organized trauma system. They may have hospitals that can take care of trauma patients. Somebody gets injured, they can be taken to a hospital, but it's not well organized into a system. So whether those hospitals, I don't even think they have levels of trauma center over there, or anywhere in Latin America, quite frankly. So you don't quite know the level of care you're getting at a particular institution. And the other issue without having a formal trauma system set up is that, for instance, when you go across the river here, there's a couple hospitals here in Tamaulipas where you could probably get good care. And then if you can make it to Monterrey, another 120 miles, the level of care is amazing, as you would expect in a large American city. In between there, for that 120 miles, there's an assortment of 5 or so rural clinics that are staffed mostly by physicians that are still in their training years, completing their servicio social years, which are at the end of medical school. And then at the end of residency, they again have to do some social services time where they're unpaid or low pay, and they work in these rural communities that a lot of people don't want to work in. Between here until you get to Monterrey, if you get in a car accident or a motorcycle accident or something like that out there, that's all you get, and there's no formal mechanism for triage, transport, or getting you to Monterrey. they would have to call and work out something on the fly, whereas here everything is kind of coordinated. You go to a lower level trauma center, they make the phone call, the helicopter picks you up, it's all automated there. It would be all fly by the seat of your pants. And those smaller rural centers over there, before you get to Monterrey, I don't know if any of them even have blood products. So if you get into a bad car wreck, end up in one of those places needing blood to save your life, they won't even have the ability to give it to you. So drive safely until you get to Nuevo Leon, and then you'll be okay.
It just makes us not feel how lucky we are to be in an urban area that's reached the level it's reached, that we have that better service.
But we want to help them. We see ourselves as, South Texas, like you said, many of the people here on this side of the border have cousins, aunts, uncles, family, even spouses right on the other side. Many of them work over here, live over there, or vice versa, live here, work there. It's a big border community, and so your question about overflow from there, absolutely. If somebody gets into a real bad traumatic event, or whether it be a gunshot wound, a bad car accident, or motorcycle wreck, a lot of them will do their best to try to make it across to here, because if they can make it over the river, once they get to a hospital here, we can't turn them away if they need emergency care. That's a law going back to something called EMTALA, EMTALA.
It's an international agreement.
No, it's EMTALA has to do with all the hospitals in the United States cannot turn away anyone that seeks emergency care. I forget when that was put in place, probably in the 70s.
Okay.
So basically, if somebody shows up, doesn't matter where they're from, who they are, they get the same level of care as anybody else. If it's an emergency, if it's elective, outpatient type of things, then they have to figure out how to pay ahead of time.
Yeah.
But for emergencies like trauma, we can't turn anybody away. So yes, we do get spillover from there. Just recently, we just operated on a gentleman who crashed his motorcycle over there, but was an American citizen and was transferred from a clinic there to here, specifically so we could do a thoracic reconstruction on him, which I'm sure we're going to talk about in a bit.
Okay, thank you for explaining that. Next question, who does the DHR Health Level 1 trauma team consist of?
Oh boy, like I said, a trauma center it really is the hospital. It's not like you have a separate little clinic or building, it really is the whole hospital. So the answer to that question is it consists of everybody, but the core people that make it up are the trauma surgeons, the ones that you would encounter let's say the ones that you would encounter as a patient, would be the trauma surgeons, and of us there's 8 of us that take call here. The surgery residents who are rotating through the trauma service. We have the first surgery residency in the region down here, which is, I think it's in its 7th year now, so we're very proud of them. And some of them are going on to complete fellowships in trauma, then become trauma surgeons here or elsewhere. But you would meet the trauma residents, the trauma surgeon on call, who may be me or one of my partners, the trauma nurses that work in the emergency department physicians, and if you need to go to the operating theater, you meet the anesthesiologist and all our crew as well. And anyone else you touch along the way, the ICU nurses, the floor nurses, so you can see all the way to rehab. So really you can see from door to leaving, it's the whole team. Not only that, all the research we have to do is a whole other separate research institute run by Dr. Betancourt and Dr. Rao. And without their help, we can't continue to do the research to improve care for our patients locally as well as nationally. Here in the department, there's this whole area back here, the office area, is run by the back end of the trauma team. They're mostly trauma nurses, including our trauma program manager, Jennifer Volsey, who run all the back end. You can imagine when we're taking care of all those patients, there's an enormous amount of paperwork to be done on the back end. And I'm not talking about billing, that's separate. I'm talking about monitoring for quality improvement. You have to have a large amount of quality improvement processes in place to monitor to make sure that you are adequately taking care of patients, and that data that if you take care of those patients gets uploaded regularly to national level databases. So it's a tremendous amount of work to monitor and keep track of all those patients.
So it really is computerized these days.
Big time, but there's a lot of manpower involved because they have to go through the charts. They can set flags to catch certain things that happen to patients, but then there's a huge amount of manpower perusing through the charts